Let's see. Okay. Where do I go from here? Present. If I do that, does everybody see it?
Yeah.
Okay. So when I was thinking about what to include in this, 10 minutes is not a lot of time, right? This is the kind of stuff that like we could probably spend hours teaching somebody else. So I try to just include the things that I find make the most difference in latching when we're helping clients versus like what I might teach a client prenatally about a good latch, right? Where we don't need that level of stuff. I figured, we can go a little bit beyond into the real mechanics of it. And again, this is just in my experience, what I find and what works and what I've learned, and not necessarily what works for everybody. I don't have a slide or spend a lot of time on actual positions like football versus cross cradle, because we all know that those are all just unique to the family, right? That it's whatever they're comfortable with. And the latch itself is more about how they're attaching. So just to keep that in mind, like when we're doing, whatever position is best for that client, we might choose a football hold because they've had a C-section. We're still going to look at the same kind of oral mechanics for the latch. So just to put it out there that there isn't really a full section on that. I had to not include everything. So I kind of just wanted to start with a conversation on what I think we do know. I have to try to figure out a way to move this screen because I can't see all of my own slides. Hold on. Okay. We know a few things about a good latch, right? By definition, a good latch doesn't hurt. We know that it's very common for a latch to hurt, and we even hear people say things like, oh, it's going to hurt for 2 or 3 weeks and it goes away. But if that was the case, everybody would have a painful latch for 2 or 3 weeks, right? We know lots and lots of families who never experience any pain with latching. And so by definition, we would hope that a good latch does not hurt. And I hate the word good, and I don't even love that I used it there. But a asymmetric latch or optimal latch doesn't hurt. It's kind of the goal, right? That, normal human experiences that we have to go through multiple times a day shouldn't pain us. Going to the bathroom shouldn't, and all kinds of other things. And I kind of put latching and feeding our babies in that category of normal everyday processes. So I'm usually encouraging families to keep finding better solutions or keep trying different positions or keep, moving to different angles until they find resolution of the pain. We do know that latch mechanics impact jaw and tongue function, right? So the way a baby's latching on is going to help determine whether that their tongue's working optimally, whether their jaw's opening optimally, and those two things, of course, drive milk flow. So the better our tongue's working and the better our jaw can open, the better, deeper latch we can get, the more palpitation of the breast we get, and typically the more milk flow. I talk a lot about latching and extension or open airway latching, sort of as a crux to a good latch, because we all sort of course know that if I'm going to pick up my coffee and drink something, I'm not going to do this, right? Right, we just know that we don't tip our chin down, close our airway, and then try to do anything with our tongue, right? I wouldn't talk to you like this the whole time we're talking. I can't get my words out. I can't swallow in that position. I can't lift my tongue, click my tongue. So we know that the way the mechanics of the latch are going to impact jaw and tongue function. Wide open jaws allow for the tongue to get more of the areola below the nipple, and that's the key, right, for good milk signaling. I don't have my knitted breast. I'm kind of mad at myself. I usually have my trusty little knitted breast to use, and I left it at the office today, but my hand puppets work. So one of the things that I think we all understand is that when we're latching onto the breast, if we latch in a very equal way, the tongue only gets a small amount of space to work, right? If we latch in an asymmetric way, the tongue gets a lot of space to work, and it can do a better job of signaling for that milk ejection reflex. So when we talk about jaw and tongue function, that's mostly what I'm talking about. The tongue being the main signal to the parent's body, causing the oxytocin release, right? So the baby's latched on, they're signaling to the parent's body through that nibbling, and that nibbling tells the parent's body to release oxytocin, which then squeezes breast tissue or muscle in the breast, just like it uses the same function of oxytocin release to squeeze with contractions in labor. And we see milk eject, right? It's one of the reasons why we can, if we're nursing, hear a baby cry across the room and have a letdown in our shirt, right? That crying signaled oxytocin, oxytocin squeezed muscle, and muscle pushed milk out. So that signal system is important. If we have poor upward tongue mobility, so if I'm tucked down like this and my tongue is not lifting, right, of course I'm going to have suboptimal signaling for that milk ejection reflex. We could have a ton of milk in the breast and a baby who can't get enough. We have all had those clients, right, who can pump 6-7 ounces, but their baby can only transfer 1 or 2. Right, and that's going to be an issue with the latch itself and how well that signal system's working. From my experience anyway, most often it's not an issue of having enough breast milk when we're seeing, for example, weight issues or low transfer leading to other issues like refusal. And it's often more of an issue of that poor signal or poor transfer. Okay. So just to kind of go to this part where, you know, what makes a great latch. Again, I mentioned that I'm not talking about positions necessarily, not like cross cradle versus laid back versus football, because in all of those positions, the mechanics of the airway matter just the same. So the 3 things that I'm looking for to help families, like I'm assessing first, is whether they're latching an extension. If they're pushing the back of the baby's head at all, we know we have a problem, right? Because we're closing off extension, closing off tongue function. If their posture is tight, you know, those little football, I call them football player babies, those tight little guys or girls that have a hard time opening up. They'll have a hard time getting into extension just because they're still quite tight. And we might look at things like tummy time or arm circles or other things that help open them up. Infant massage that you can do yourself with babies, or you can teach parents to do themselves with babies. But basically, if we can get a baby to latch an extension, what we're doing is we're allowing them to have their full open mobility of their jaw, right? That I can't open my mouth when I'm looking down. I can open nice and wide when I'm looking up. If we're not putting a baby in extension, we're not giving them the opportunity to open their mouth wide and get that deep latch. Right? So more important than like fishy lips and flange lips and all that kind of stuff, I would say is actually whether or not we're giving them the opportunity for that function in the first place. Second to extension, we're looking at that asymmetric placement of lips, right? That if a baby latches on over top of the nipple and their bottom lips here and their upper lips up here, well, now their tongue is trying to work in a very small space, right, to try to get milk out, and we're going to get compression of the nipple from the bottom up and usually quite a bit of pain as a result, versus having that baby latch asymmetrically from nipple down, right? So the upper lip's just covering the nipple and the lower lip is as far below as possible, so the tongue gets all this wonderful space inside from the nipple down to work and do all that work of signaling, right, for good milk transfer. So once an extension, asymmetric placement of lips, we're often teaching parents, right, how to open that bottom lip, how to kind of pull down the jaw while the baby's latched, or to try to just get a little bit more movement there. And again, I know I'm talking to a group of people who already know all this stuff, so please, you know, I feel kind of awkward about it, to be honest, but just one of the things that I see a lot in maybe, for example, the students that I have come with me, is they're always trying to pull down that jaw before they get baby an extension, right? And you can imagine if I'm here, there's just nowhere for my jaw to go. Anatomy tells us, right, that we actually just can't do that work, and we really do need to make sure we're getting an extension first and then helping baby open their mouth. So whenever we're correcting a latch that's already attached and maybe pulling baby back a little bit, we might get them into airway position, but then we need to still open their chin. So that's what I mean there by the asymmetrical placement of lips. And then the open loose body posture. There's a lot of tight babies out there, and we know that tension in the upper body restricts movement, right? If I want to look up at the ceiling, because that's what a good latch position looks like, but my shoulders are tight, well, now I can't look up, right? Now my neck function is restricted, and it's not because there's anything wrong with my neck on its own, but if my posture is tight, my neck doesn't get full mobility. So when we're looking at our little babies who have just been tucked up inside for so long in that sort of real fetal position, some things that I love to talk to babies' parents about is giving them loads of unrestricted movement, right? So reducing the amount of time they spend in swaddles, in car seats, in baby chairs, in, you know, and anything that, like a swaddle, I know that you can only see my face, but, you know, a swaddle keeps a baby sort of tucked in like this, right? With their arms in, swaddled up. And we know that that restricted movement isn't helpful, right? For them to unwind after birth. And the quicker they unwind and open up, the better they latch, and the quicker some of that nipple pain goes away or milk transfer increases. So looking at body tone as part of what makes a great latch. Okay, I just always, I can't talk about latching without talking about reflexes. You guys know this stuff. But the basics for me, and again, in context of working with a baby who's not latching well, is going back to the basics of what they actually were born knowing, which is their feeding reflexes, right? So we know they're born with those reflexes to feed properly. We've all seen the videos on the breast crawl, and that if we get out of the way, they'll often find their own way there and attach in a pretty good position. This is just like a stock photo, but I thought it was a fairly good representation of our nice laid back, possibly right after a breast crawl, right? Or baby just finds their way to the breast. What typically happens is the way they crawl over puts them right under the nipple, and then they have to like bash their head. You know how they kind of do that, that real head bob, and they bash their head and they eventually get their mouth around the nipple. And what happens is a laid back position almost forces a good latch because the baby has to reach up to the parent's breast or chest. So I think a lot of us love this position because it's like a self-correcting position, right? It allows the baby to get in extension without the parent having to maneuver that extension. I don't know if that's all making sense to everybody, how I think it. But you know, a lot of times, especially in those first 2 to 4 months before those neonate reflexes have integrated into bigger, better ones, we can really rely on their ability to root, gape, crawl, step, right? All those reflexes are helpful if we know how to use them. I'm not going to spend more time on that. I think that we all kind of know that stuff, right? And I have you all to the side of my screen, so I don't even get to see like head nods or anything. I'm a big fan of feedback. But hopefully that all makes sense. So steps to latching, right? When I'm teaching a parent about latching, I'm trying to be as simple as possible. They don't need 37 steps, right, to getting the best latch. They, you know, they need some simple steps to follow. And I usually do spend some time talking about the anatomy. I think that when parents understand exactly what's going on, they know how to use that information well, even without our help or guidance. So once we've talked about how important the open airway is for tongue movement, for jaw opening, then we can talk about those steps to latching. We know these things, right? Nose to nipple, nipple to the roof of the mouth. There's all these taglines that parents are like, but I know that. And then you watch them try to execute it and you're like, you didn't quite get it. And it's because those words can mean very different things to different people. So what those words mean to me anyway is that we want the nipple up to the nose, so the baby has to elicit the root reflex, right? So if we're tapping that upper lip with the nipple, we're trying to get the root reflex. And once the baby roots up, we wait for the gape reflex, right? So they reach, they open, and once baby gets themselves into their own open airway position, just because we've lined them up the right way, we want to be so careful not to tell the parent or to watch and see if the parent is sort of scooping in on the back of the baby's head versus pushing through the middle of the back. For a good latch position, that's what I think we all probably see it quite often is baby lines up beautifully, opens wide, and then the parent pushes the head and closes off the airway, tucks the nose in, and what looked like a great lineup ends up in a really painful or less optimal latch position. So I find that those words help the most with parents, like nose to nipple for sure, but let the baby reach. That part I think gets missed, or at least they don't pick up on it when they've been told before. So let the baby reach. It's your job to line them up as the parent. It's the baby's job to reach and open, and then it's the parent's job, if needed, depending on the position, to kind of guide them in through their shoulders or mid back. Right. So we always want that open posture, right? If I push you through the back of your shoulders, you can still look up at the ceiling. If I push the back of your head, I'm tucking your airway and giving you a less optimal latch position. And then talking to parents about how they support their baby. A lot of times they'll latch and then they'll shift their arms to the back of the baby's head and push in. And then all of a sudden, you know, we have a latch that might lead to poor milk transfer after those initial nice letdowns, right? Just because that tongue function is not there. So nose to nipple and let the baby reach. Once the baby reaches, we wait for gape. If we do this over and over again, those babies who won't open and reach will. They just need to go through the motions and create the muscle memory for it. Guide through the shoulders, never the back of the head, and ask them to support the shoulders. I put in number 6, manage the milk flow, because I guess, you know, we're LCs, we see problems. So a lot of times what we're dealing with are not the babies who are just like, you know, born and latching well and drinking well. I love those consults when we get them, but I don't know that I ever really get to see those babies. Typically, right, we're seeing babies who are having trouble getting enough milk, causing pain for the parent. So managing the milk flow is a big piece to the latch in my mind. Because if we can help that baby eat very, very efficiently and spend less time at the breast, we might then have less overall pain. If we can reduce the amount of nibbling happening, right, that request for more milk versus a lot of nibbling, we can reduce pain and vasospasms, right? Less time to do that kind of compression on the nipple. And also, of course, if a baby's not gaining well or not transferring milk well, we want to manage the milk flow so they're not doing a lot of asking, right? So that the request, their asks of nibbling is being met with good milk flow. I think we're going to get a little bit more into that in a minute. I just put this slide up here because I like to make things fun and interactive. So I don't know, I can't actually see you guys to see if you're going to participate with me, but these are some fun ways to help explain to somebody who may not understand why positional restriction is a problem. So positional restriction meaning like I have no restrictions, I don't have a tongue tie, I don't have tight jaw muscles, but the moment you put me in this position, I can't use anything, right? The moment I tuck in like that, I can't use my tongue, I can't open my mouth, I can't swallow. So a positional restriction is how I refer to that. Where a lot of babies, that's all it is. They're experiencing a positional restriction. And so, you know, if you look down at your chest and say lollipop, you can feel it, right? If you try to like roll your R's, I just can't do it. You know, I'll sometimes ask parents to do these things. Click your posterior tongue blade, like the blade of the tongue, right? While looking up at the ceiling, I get nice loud clicking sounds. And if I do it down here, I can barely use my tongue in what would be very similar to the undulation we want to happen while latching. We wouldn't swallow something looking down. And then when we're looking at a wide, deep latch, right? So we have the breast, we have the mouth, and we want that mouth nice and deep past the nipple to cause no pain versus shallow, right? Which we know causes pain. We need a full open mouth. And so many babies are latched in like this with their chin tucked, which we know reduces jaw capacity, right? So if you do it yourself, I'll do it for you if you just want to make me look silly. But if you look up at the ceiling and open your mouth as wide as you can, and then you slowly bring your chin to your chest, you'll feel how your jaw closes without you trying to. You just can't keep it open, right? It just closes right up. So we want a deep latch. We need airway extension, right? We need that position. And I just kind of put their flange lips and a poor neck extension. Don't make a better latch, right? If we're just looking for that the fishy lips, I think a lot of parents come in saying, but the fishy lips, I got the flange, you know, the lips are open and it still hurts. And it's like, yes, but the neck is more important. So I just threw some pictures up just from my own collection. These are pictures I have permission to use, but please don't like screenshot and share them outside of our own educational resources. I don't have permission for that necessarily, but I have them permission to use them for education. So here's 2 babies, both latched on. You know, and if we look at the pictures for some of the markers of a really good latch, right, we're looking at, you know, is the chin up off the chest, above 90 degrees, ideally, right? Is that nose away from the breast? And is their areola showing on the top and not the bottom, letting us know that there's asymmetry? So if we look at the picture on the left, right, we got the nose away, we got the areola on the top, but look at his look at his neck function, right? He's all tucked in. You can see that little double chin or triple chin trying to form. And so his tongue won't work as well as the baby on the right, who also, there is areola at the top. The nose is away from the breast, maybe not as much, but that's less important. His chin's up above 90 degrees off his chest. Right? So they look very similar, especially if you don't know exactly what you're looking for, which most parents don't, right? Most parents have no idea these little millimeters of difference that can lead to a big difference in latching. Okay. So here's something I love to do for clients. I've been doing virtual consults for 5 or 6 years, and I find that it's hard, right? Sometimes to really tell them what we need. So I'll draw pictures like this. Grab a picture of the baby and then visually show the parent where to change what they're doing. So almost always, again, you can see that there's more areola at the top, nose is off the breast, but you can see her thumb, right, pushing away. So she was told by somebody that the nose needs to be clear. So she's always used her thumb to pull the tissue back, which doesn't change the neck extension at all, right? The nose away is actually a function of the neck extension. The nose drops away because the chin raises up. So this, that's where terminology can be tricky. She just thought she was doing the right thing by pushing the breast away from the nose. So anyway, to correct this latch position, right, we would need to get that baby's head tilted back more. There's almost a straight line between his back and his head versus more of a tip back head posture. Her wrist is bent out instead of pushing in. Do you see that? Right? So if her wrist was pushing in more, his chest would raise, his chin would raise, and he would tip back into extension. So this is a football hold, particularly difficult one, right? To get a good latch because the kid literally needs to be behind you. But any position, right, would use very similar corrections if there's pain or poor milk transfer. Let's see. I'm trying to be cognizant of time as well. Sorry, guys. Throw up a slide around flow management, right? So once we're in that good latch position, it's pretty important that we're watching for milk flow, helping baby get more milk flow as needed, switching sides based on baby's cues. And I think, sometimes it can be tricky for parents. They often think that, if a baby's fallen asleep at the breast, they must be done. And then they'll spend an hour trying to burp a gassy baby when all they have is really just a baby who's still hungry, acting very similarly to a gassy baby. So flow management, I find, comes in really helpful when we're helping parents finish feeds or have really efficient feeds. Getting the best latch possible, which is kind of what we're talking about today. Watching the drinking, right? Knowing how to tell the difference between quicker nibbles at the breast and longer pauses or mouthfuls. And again, I know that you guys know this stuff. But for a lot of babies, they could be drinking very well, move into nibble, nibble, drink, nibble, nibble, drink, and come off angry because that change in flow is too much for them. Whereas another baby might only ever get nibble, nibble, drink, nibble, nibble, drink. And that's like optimal for them, right? So it's hard because we have to sort of watch what the baby's expecting and compare what's happening to the expectation versus just what's happening, which could be ideal for another baby. So getting the best latch, watching the drinking, when the drinking slows, moving to breast compressions to speed that drinking back up again for the baby. And then when breast compressions are no longer helping us get mouthfuls, switching sides, starting back at step 1 on the second side, and then repeating as needed, right? So we know that they can go back 4, 3, 4, 5, 6 times if they want to. Some people don't let down easily, and we have to chase the letdown from one side to the next and back and forth, versus other parents who find they can get 1 and 2 and 3 letdowns on one side before switching to the next. And it really doesn't matter at the end of the day if the baby's gotten 1, 2, 3, and 4, or 1, 2, 3, and 4. I hope this makes sense. Because at the end of the day, they're getting enough milk, right? And they're getting it in a way that's not bothering them or making them frustrated. So just the idea that babies respond to milk flow, right? They're too smart to use up energy that isn't successful. So if they're nibbling, asking for food, they will do that until they either get more milk or until their body's decided that they've put out more energy than they should have, with nothing really coming in return, and they shut down or fall asleep, right? That's that kid, we all know that baby. We work with them every day where the mom or dad or partner or parent, whoever, thinks that the baby's done because they fell asleep, right? Versus recognizing that they fell asleep because the milk wasn't flowing. And then, we can lead to a lot of frustration and poor latches, right? So I point this out because when we're talking about a good latch, babies will adjust their latch to shallow to stimulate the nipple to cause more oxytocin. We know nipple stimulation will cause oxytocin. We use it in labor and birth all the time to speed up contractions, right? If before we go to other interventions, it's an old midwives trick, and that system, right, is going to respond to the flow itself. So if that milk flow slows down, babies slip to try to make more, and now they're in a poor latch position again, which can be painful. So this is usually what's happening when the latch is fairly comfortable and then gets very painful towards the end of the feed. It's often a result of that nibbling, and that's that baby saying, I want more milk, please get me more milk, hello, let down, right? Mama's body, parent's body. And if it's not letting down, they'll just keep going until they get what they need, or until they have to go into that energy conservation mode. So helping families recognize this and have nice efficient feeds tends to increase milk transfer, of course, but also reduce nipple pain, right? Because they don't have to slip down and cause that like munching on the nipple. We've already taken care of the flow for them. And I just threw up some pictures of more latch corrections to look at these babies on, because they're latches that a lot of people might say, oh, that's a great latch. But if we look closer, we might notice that the head and neck posture on the baby on the left is still pretty 90 degrees. If I go up through the shoulder, through the ear, and then through the nose, right? Whereas I would want that angle to be more like this, right? The baby's head tip back further. Same with the little one in the middle, right? We're looking at getting the chin up off the chest more, that nose falling away further. And the way to do it is to maneuver the body further around the corner of the opposite breast. So further tucked away. And then the last picture, same idea, right? We're looking at a good markers like asymmetry and nose away, but the chin, the airway open position isn't there. And so all these families, all three of them, had nipple pain in this position. And when we went through those corrections, they reported that it was pain-free at that point. So just summary of latch mechanics, right? Open airway, allow upward and posterior tongue undulation, that it's asymmetric, right? The tongue needs the most real estate to palpate the breast, give a good signal, cause release. The baby's not the one removing the milk, right? So remembering to talk, if you agree with that, to talk about it that way. It's not like the baby's sucking milk out. They're just signaling, and then the parent's body is responding. Right? So when we are looking for solutions, we want to figure out what part of that system is breaking down. Is it the signal, right? So maybe the baby's posture has to open up with different position. Maybe the airway is closed. Maybe they're too bullseye and not symmetric enough on the breast. Or is it to do with the parent's oxytocin response? Is she super stressed and can't let down, right? We see that all the time. Does she actually have a low milk supply? Are there physical blocks to transfer, like a nipple shield, right, causing reduced transfer, or blocked ducts or other things that can cause reduced transfer? And then the feeding reflexes. A lot of babies that we work with probably have had a ton of bottles and other feeding methods, and we're getting them back to the breast. And sometimes we really have to work on integrating those feeding reflexes, or sort of rehabilitating those feeding reflexes so they get back to touch, open, gape, latch, right? So a lot of babies later on, around 6 or 8 weeks, have kind of lost those reflexes because they haven't had to use them with bottles. And we know there's tons of exercises and things that we can help the families with to help them regain those reflexes and therefore regain really good breastfeeding. Talking about breast compressions with families, and I know we all probably recommend them. Sometimes it's helpful for families to know that, that oxytocin release is happening because of how good that latch is. And if the latch is great, we get good oxytocin release. But even with that, we might find that breast compressions help speed up milk flow. And what we're doing is we're just manually compressing the breast in place of that oxytocin response that for whatever reason in that moment isn't occurring. And then I think I already mentioned this part that, when we're looking at sore nipples, compression to the nipple based on that jaw being tight or the tongue being tight, positional restrictions, right, with our airway position, kind of keep needing to be worked out until latching is pain-free. So opening the airway, lowering the bottom lip, supporting through shoulders and not the head, and trying to play around with those things until we find the parent says, okay, that's more comfortable, I can do this. Okay, well that's it. I ran through it really quickly. There's nothing else for me to share. Like I mentioned, the last thing I would have wanted to talk about is different positions and how to get it, but I think we're all probably pretty good at that already. Yeah. So I'm going to stop sharing my screen and stop talking. Thanks, guys. Thanks for listening.